My name is Tabitha Mounteer. I'm a nursing student at the University of South Alabama, and today I'm going to be performing an NG2 placement. First, let me show you my ID, and then I will quickly scan my room. So the first thing I'm going to do whenever I walk into my patient's room is verify the orders and also verify my hospital's policy. So the next thing that I'm going to do will be to perform hand hygiene, and then I'm going to verify that this is the correct patient using the patient's name, which is Jaguar Jones, patient's date of birth, which is 08/25/1963, 08/25/1963. I'm also going to note that on the patient's chart and on the patient's armband there is an allergy to penicillin. I'm going to explain the procedure to my patient and then provide patient privacy. Next, I would gather all of my equipment that I needed and then don my goggles. And my stethoscope and my pen liner in my pocket ready for me to use. So the next thing that I'm going to do would be to raise the bed to a comfortable working height, lower the side rail, and assess my patient's vital signs, oxygen saturation, and auscultate my patient's bowel sounds. So the next thing that I would do would be to realize that if there is a drop in oxygen saturation or a deterioration in any other vital signs, that the NG placement should be stopped until the patient's stability is identified. So the next thing that I would do would be to raise the head of the bed to high Fowler's position, establish a cueing sign with my patient that meant that the procedure needed to stop. Then I would prepare my tape, which I have already pre-cut all of my pieces of tape, but I would need to prepare my tape before the procedure. Next, I would first I would open my nasogastric tube, place a dollop of lubricant on the inside of the package, and then I would need to take the tube out and measure how far to insert, but I have already done that with my volunteer patient, so it is already marked with a dog-eared piece of tape. The next thing that I would need to do would be to place a towel over the patient's chest and place a basin over the patient's abdomen. So the next thing that I'm going to do is going to be perform hand hygiene and apply clean gloves. Now I'm going to remove the NG tube, curl it around my hand, and release, and then I'm going to lubricate 4 inches of the end of the NG tube. Then I'm going to instruct my patient to push their head backwards towards the pillow, and I'm going to insert the tube down to the back of the nasopharynx. And then once I've done that, I will tell my patient to relax and then lean their head slightly forward, give them a cup of water with a straw, and allow them to sip water while I insert 1 to 2 inches at a time, gently rotating 180 degrees. During this procedure, if the patient begins to show a decrease in oxygen saturation, or the patient begins to cough or shows any other signs of respiratory distress, I would would pull back the NG tube to the back of the nasopharynx, and then once the patient resumed normal breathing, we would continue the procedure after the patient began to swallow before I started inserting the NG tube. So we've reached my dog-eared piece of tape, which means that this is how far that we should advance the NG tube. So now that I've done that, I'm going to take one of my prepared pieces of tape and I'm going to temporarily secure the NG tube to the patient's cheek to hold it in place. So the next thing that I would want to do would be to clean the bridge of the patient's nose, and then I would want to remove this dog-eared piece of tape and place this piece of cut tape onto the NG tube in the patient's nose to allow the NG tube to float. So the next thing that I would want to do would be to check the placement of the NG tube in the back of the throat with my pen light and a tongue blade. The next thing that I would want to do would be to loosen the plunger of the 60 milliliter syringe, and then I'm going to attach it to assess for correct placement of the tube. So there are 3 ways to do this. You can assess by aspirating gastric content, testing the pH of the gastric content, and also having an x-ray done if ordered. So after I've aspirated, I can detach this and discard of it. So if the NG tube is not in use, I can place the pigtail over it and cap it. If suction is needed, I would need to take the suction from the wall and attach it to the tubing and turn the suction on low wall intermittent suctioning. When using a Salem sump NG tube, this pigtail has to be above the level of the patient's stomach at all times. So again, if you're not using suction, this can be capped. So after I have inserted the tube and secured it properly, I would also have to clip it to the gown. I could reposition my patient, lowering the bed no lower than 30 degrees elevated. I could raise the side rail back, lower the bed to the lowest position possible, have the call light and all other comfort items within reach of the patient, and then I would discard all of my garbage, get rid of the towel and everything, and then I would document the size and the type of tube that was inserted, how the patient tolerated the procedure, the type, the amount, the color, consistency of the gastric contents, if suction was used, how I verified placement, and the patient's vital signs throughout the procedure. So that is how you place the tube. So if I was done, after I was done with the procedure, I would remove my gloves, and then to remove the NG tube, I would don new clean gloves. So to remove I would remove the piece of tape that should be on the patient's nose, unclip it from the gown. If it was hooked up to the suction, I would have to first unhook it from the suction. And then what I would do would be to tell the patient to take a deep breath and hold. And then I would clamp the tubing on itself and pull the tubing out of the patient's nose and then discard. And then after doing this, I would also have to document how the patient tolerated this procedure, the type of secretions and everything like that.